This recorded lecture will be going over Chapter 40, Care of Men with Reproductive Disorders. The urinary system and reproductive system are so closely linked in the male that a disorder in one system is likely to affect the other. Privacy should always be provided when assessing the genitals, performing catheter care, or doing dressing changes. You must be professional and display an objective, professional manner when providing care. Erectile dysfunction, also known as impotence, is the inability to consistently achieve or maintain an erection that is firm enough for sexual intercourse. ED has psychological, called psychogenic, and organic causes, including vascular, neurologic, cavernous, hormonal, or drug-induced origins. Factors that interfere with the mechanisms of penile erection will cause ED. Any condition that impairs the blood supply to the penis, impairs nervous system function or hormonal supply, or impairs psychosocial responses can interrupt the process of penile erection. Organic causes can include diabetes mellitus and other endocrine disorders, disorders of the urinary tract, neurologic disorders, and chronic illness like sickle cell anemia, hypertension, cardiovascular disease, liver disease, and cancer. Some antihypertensive drugs, diuretics, tranquilizers, and medications used to prevent GERD can cause sexual problems. A complete history and physical examination will help in ruling out illnesses that may affect sexual performance. Sleep laboratories can monitor nighttime penile erections to detect organic causes of impotence. Review the patient's medications for side effects affecting erectile dysfunction and conduct a complete evaluation for psychological causes of impotence before devising an individualized treatment plan. Treatment will depend on the cause of ED. The primary intervention for ED is modifying reversible causes of the problem. Drug therapy includes phosphodiesterase inhibitors taken as directed in a period before sexual activity. These drugs should not be taken with nitrate-based drugs because a serious drop in blood pressure can occur from the combination. If these methods fail to resolve ED, surgical interventions may include inserting a penile implant that can be rigid or flexible. Complications of oral medication therapy include priapism, a persistent abnormal erection that can develop into a urologic emergency. Asking open-ended questions concerning sexual function or problems can provide information that will be helpful to the plan of care. Referral to a sex therapist may be indicated to help the patient integrate their sexual belief, practices, and abilities into a healthy lifestyle. Spinal cord injuries, neurologic disorders like multiple sclerosis, diabetes, urologic surgery, or the side effects of various medications can cause problems with ejaculation. Premature ejaculation is the most common ejaculation problem in men. Chemical, vibratory, and electrical stimulation can be used to treat premature ejaculation. On page 954 within Table 40.1, you can read about some treatment options for ED. Retrograde ejaculation occurs when the semen travels towards the bladder rather than exiting the penis. Determining the physical and psychological factors causing the retrograde problem is the priority for selecting the appropriate treatment and planning care. Infertility is defined as a failure of a couple to achieve a pregnancy after at least 1 year of active, unprotected intercourse. In 10% of cases, a male factor was the only identifiable cause for infertility, and in 35% of cases, a male factor was identified along with a female factor. Hypothalamic pituitary disorders and ED contribute to infertility, but testicular disorders are the most common organic cause of male infertility. Drugs, infections, systemic disease, and congenital disorders can cause testicular failure. A semen analysis with sperm count and activity can be performed. Laboratory tests like the FSH, LH, and testosterone levels to determine whether hormone therapy will be indicated. A fine needle aspiration or biopsy of the testicles could reveal pathology that can be treated. Pathology may be corrected with medications, hormone therapy, or surgery. In vitro fertilization or in cytoplasmic sperm injection after sperm extraction is often successful. The environment should be evaluated for toxins like pesticides, lead, mercury, or radiation exposure, all of which can affect fertility. Patients seeking fertility should be instructed to prevent excessive heat around the scrotal area, which could decrease sperm development. Hot tubs, using a laptop on the lap, and tight underwear should be avoided. When infertility is attributable to the man, his self image may be affected. Therefore, objective, caring, and considerate family interactions are essential. There is normally a small quantity of fluid in the space between the testes and tunica vaginalis within the scrotum. A larger than normal amount of fluid accumulating in this space is known as a hydrocele. The fluid accumulation could be caused by infection, such as epididymitis or orchitis, or accumulation that may occur after trauma. Hydrocele involves interference with lymphatic drainage of the scrotum. Hydrocele causes enlargement of the scrotum and usually is painless, but the weight and added bulk of the fluid can cause discomfort. Treatment, when indicated, is aspiration or surgical incision and drainage of the sac. Dilation and clumping of the tributary vessels of the spermatic vein cause a painful swelling called a varicocele. The discomfort is rarely enough to warrant surgery. If infertility has been a concern, surgical correction via injection of a sclerosing agent or ligation of the spermatic vein could improve fertility. Nursing measures to help the patient cope with fatigue, weakness, and fever are appropriate because these problems are commonly associated with urogenital infections and surgical procedures. Teach the patient to wear scrotal support after any intervention. Testicular torsion is a twisting of the testes and spermatic cord. It is commonly caused by elevated hormone levels in young adult men, but can also result from scrotal trauma. Signs include sudden acute scrotal pain and an absence of the cremasteric reflex. This is the retraction of the testicles when the inner thigh is stroked. Nausea and vomiting may also occur. A Doppler ultrasound scan could reveal diminished blood flow and confirm this diagnosis. To prevent testicular ischemia and necrosis, emergency surgery can be performed to secure the testicle within the scrotum or to remove the testicle if necessary. Priapism is a prolonged penile erection resulting in a large, hard, and painful penis, unrelated to sexual desire or activity. The cause can be neurologic, vascular, or the result of medications, like those designed to increase sexual performance. The most common disease that causes priapism is sickle cell disease, which causes a local accumulation of erythrocytes that results in engorgement of the corporal bodies. Circulation to the penis may be compromised, and voiding may be impaired while the penis remains erect, so prompt treatment is essential. Treatment can be conservative to promote dilation of vessels in order to relieve pressure. Sedation, bed rest, warm baths or enemas, and urinary catheterization may be prescribed. Aspiration of the corpora cavernosa with a large bore needle or a shunting procedure to divert the blood may be necessary to prevent ischemia to the penis. Peyronie disease is a condition in which a plaque of non-elastic fibrous tissue develops in the tunica portion of the dorsal corpus cavernosum of the penis. The loss of elasticity in that section of the penis results in the inability to have a uniform erection of the penis. Inability to penetrate the vagina may result, and the erection may become painful as well as embarrassing. Conservative treatment includes local injections to dissolve the plaque. Diagnostic tests for the male reproductive system will be discussed later on and can also be seen partially on page 958 and tables 40.2. Enlargement of the prostate, also known as benign prostatic hyperplasia or BPH, occurs when the prostate gland enlarges and extends into the bladder neck, causing obstruction of urine flow. Prevalence of up to 60% has been noted by age 60 years and 80% at age 80 years. BPH produces no symptoms until the growth becomes large enough to press against the urethra. Then the patient will begin to experience difficulty in urinating, evidenced by a decrease in the strength of the stream of urine, hesitancy, and dribbling after voiding. There may be frequency, nocturia, and urgency resulting from the irritation of the distended bladder wall. Gradual dilation of the ureter and kidneys can occur. Nitrogen, excuse me. Nitrogen products can accumulate in the blood, and the back pressure into the kidney will inhibit glomerular filtration, eventually causing renal failure if the urinary obstruction is not relieved. A digital rectal examination will reveal an enlarged prostate. The gold standard test for bladder outlet obstruction is increased bladder pressure relative to urinary flow. Pressure flow studies, known as urodynamics, can be performed. A transrectal ultrasound differentiates BPH from prostate cancer, and a serum creatinine level can rule out renal insufficiency. If the patient cannot void, immediate catheterization will relieve the emergency problem, and follow-up care concerning the cause and severity of the prostate enlargement can then be completed. Drug therapy includes the following: alpha adrenergic blockers, which promote relaxation of the smooth muscle and reduce blood pressure. Side effects of doxazosine, terazosin, tamsulosin, and alfluzocin include dizziness and orthostatic hypotension. 5-alpha reductase inhibitors are steroids and may take several months to work. Anti-androgen agents like finasteride and dutasteride can decrease prostate size by reduced dihydrotestosterone production. PDE5 enzyme inhibitors are agents that inhibit the enzyme PDE5, thus producing increased vasodilation and inducing smooth muscle relaxation. Combination products recently have been shown to provide an improvement in symptoms and compliance. The most well-known of these is a combination of dutasteride and tamsulosin, which is indicated for BPH with an enlarged prostate. Plant extracts like saw palmetto have been shown to be effective in minimizing symptoms associated with BPH. Indications for surgical intervention include incontinence, hematuria, urinary retention, bladder stones, and UTIs. The most effective way to reduce symptoms is through surgery. This includes a transurethral resection of the prostate, known as a TURP, transurethral incision of the prostate, known as a TUIP, laser photoselective vaporization of the prostate, known as a PVP, and an open prostatectomy. Protein-specific antigen, or PSA, is produced by the prostate tissue and is elevated in BPH, cancer of the prostate, and prostatitis after prostate biopsy. An elevated PSA is therefore not always indicative of cancer. Increased screening has reduced the risk of advanced stage prostate cancer. Urinary drainage is accomplished by the insertion of a catheter using sterile technique. A high fluid intake is encouraged, and antibiotics are routinely prescribed. Preoperative teaching includes deep breathing exercises, range of motion leg exercises, the general preoperative and postoperative routine, and explanation of care for the incision, catheters, and drains. Postoperative nursing care will vary according to the type of prostate surgery performed. The general principles of postoperative nursing care that apply to all patients having major surgery are necessary for the patient undergoing a prostatectomy. Potential postoperative complications include bleeding, urinary incontinence, and bladder spasms. A high-fiber diet and a stool softener may be prescribed to prevent straining, which increases intra-abdominal pressure and can cause further bleeding. Blood-tinged urine is normal for the first few days after surgery. If the patient has a bleeding risk, an irrigation system may be indicated to maintain patency of the catheter. Some pieces of tissue and small clots may be seen in the drainage. Additional intermittent irrigation with 20 to 30 milliliters of normal saline may be needed to clear the catheter of obstruction. Strict sterile technique must be used when irrigating the bladder, and the catheter should be connected to a closed drainage system to prevent infection. Persistent bleeding, turning the urine darker than cherry red or bright red, or viscous drainage with many clots should be reported immediately to the surgeon. Traction can be applied to the catheter to supply pressure, known as a tamponade, to prevent excessive bleeding. Check frequently to see that the catheter and tubing are not kinked and that the outflow is appropriate. The patient may have some urinary frequency and burning after catheter use is discontinued. Some blood in the urine may occur for several more days. The patient who has had a suprapubic prostatectomy may have a suprapubic catheter in addition to a urethral catheter. Each catheter will be attached to a separate sterile drainage system. Residual urine can be measured afterward by unclamping the suprapubic catheter. When there is no more than 60 milliliters of residual urine after voiding, the suprapubic catheter is removed. Dribbling of urine often occurs after prostatectomy because of decreased sphincter tone, but usually stops within about 6 months. Patients who experience incontinence are taught perineal muscle strengthening or Kegel exercises for this problem, and there are given instructions in bladder training. Teaching for the procedure should have been done pre-operatively, and exercises should resume 24 to 48 hours after surgery. When the urethral or suprapubic catheter is removed, the patient must be monitored carefully for their ability to void. Any difficulty in voiding within 6 hours after removal must be reported to the surgeon promptly because a distended bladder could cause bleeding. Monitor the incisional dressings and change them as often as necessary to keep the patient dry and comfortable. Urine is very irritating to the skin, and any area that is exposed to urine drainage is thoroughly cleansed before a new dressing is applied. Bladder spasms often are a concern after TURP or suprapubic prostatectomy. Before giving medication, check to see that the tubing is not kinked and the catheter is draining well, because obstruction can cause bladder spasm. Discharge teaching will include care of the catheter, management of incontinence, maintaining hydration, preventing constipation, observing for signs of infection, and management of anxiety related to the impaired sexual function and self-image. Frequent planned urination and avoidance of irritating foods like citrus, caffeine-containing products, and alcohol should be initiated. Contact the healthcare provider if the patient is unable to void. BPH can occur if not all of the prostate tissue was removed, so an annual digital rectal examination should be continued. Many of the inflammations and infections affecting the male reproductive system are similar to those of the female reproductive system in cause and effect. Sexual partners can continue to reinfect each other until they have both been treated simultaneously. Nonspecific genitourinary infections in men, including non-gonococcal urethritis, may be caused by various organisms, but these infections present substantially the same clinical picture. Epididymitis is an inflammation of the epididymis and may result from an infection of the prostate or a UTI. A patient with epididymitis experiences groin pain and swelling, as well as pain in the scrotum. In younger men, the major cause of epididymitis is Chlamydia trachomatis, a sexually transmitted organism. Symptoms include scrotal pain, swelling, induration of the epididymis, and eventual edema of the scrotal wall. The urine may contain pus, and chills and fever can follow. Antibiotics, ice packs, analgesics, sitz baths, and elevation of the scrotum are the prescribed treatment protocol. Orchitis is inflammation of the testicle and may affect one or both testes. It may be caused by local or systemic infection or by trauma. Bilateral orchitis is serious and can often cause sterility. Mumps orchitis occurs in 20 to 30% of unvaccinated males and 6 to 7% of vaccinated males who contract mumps. Gamma globulin usually is given to decrease the possibility or severity of mumps orchitis. The symptoms and treatment parallel those of epididymitis. Prostatitis is an inflammation of the prostate that occurs from an infectious agent or other causes. The NIH uses the following classification system. Type 1 is acute bacterial prostatitis with an acute infection of the prostate gland. Type 2 is chronic bacterial prostatitis with chronic or recurrent infection of the prostate. Type 3 is chronic prostatitis or chronic pelvic pain syndrome with no demonstrated infection. Type 4 is asymptomatic inflammatory prostatitis with no subjective symptoms detected and inflammation shown via prostate biopsy or presence of white cells in expressed prostatic secretions or semen during evaluation for infertility or other disorders. Symptoms include recurrent UTI, pelvic pain, and sexual dysfunction. These can often be mistaken for BPH. The various types of prostatitis can be diagnosed with a segmented culture of initial stream urine, midstream urine, prostate fluid before and after massage, and post-massage urine specimen. Treatment includes bed rest, analgesia, bladder sedatives, sitz baths, and stool softeners to prevent straining. Antibiotics can be prescribed according to culture and sensitivity lab findings. Antibiotics diffuse poorly into the prostatic fluid, so chronic prostatitis is commonly treated with alpha-adrenergic blockers. Fluoroquinolones can also be prescribed. The patient should be taught to avoid foods that increase their prostatic secretions, like alcohol, chocolate, tea, and spices. Follow-up care to detect reinfection is essential. Cancer of the penis is rare, occurring mostly in men with HPV infections or who are not circumcised. A non-tender nodule may appear on the penis, and the biopsy will show a squamous cell type carcinoma. Laser resection of the lesion is the treatment of choice unless the cancer has spread. Testicular cancer occurs most commonly in younger men at a rate of 1 in 250 men. However, it is a highly treatable cancer. Men most at risk for testicular cancer are those who have had an undescended or partially descended testicle. Men who are exposed to diethylstilbestrol in utero also may be at a high risk for testicular cancer, but evidence-based research is lacking. All males between the ages of 15 and 40 years should be taught to practice testicular self-examination on a monthly basis. Cancer symptoms appear slowly and involve painless enlargement of the testes, backache, and weight loss. If a mass is found and thought to be malignant, diagnostic tests for tumor marker proteins like elevated levels of alpha-fetoprotein, beta-human chorionic gonadotropin, alkaline phosphatase, and lactate dehydrogenase are obtained to confirm diagnosis. Testicular cancer spreads rapidly via lymph and blood vessels. A microscopic tissue analysis is performed after surgical removal of the mass for definitive diagnosis. There are 3 stages for classifying the malignancy of testicular cancer. In stage 1 or localized, the tumor is confined to the affected testes. In stage 2 or regional, malignant cells have spread to the regional lymph nodes. In stage 3 distant, there is metastasis to other organs like the lungs and liver. If the testicular tumor is limited to the scrotal sac and there is no metastasis, a laparoscopic surgical removal of the testes, known as an orchiectomy, may be all that is necessary to cure the patient of their disease. The nursing care will focus on teaching and providing psychological support. Ice bags and scrotal support will provide comfort, and the importance of follow-up care is stressed. Further treatment for stage 2 testicular cancer could include radiation. Some men view an orchiectomy as a loss of masculinity. You can be instrumental in assisting the patient to verbalize their fears about the procedure and its complications. Carcinoma of the prostate is the second most common cancer, next to skin cancer, that affects men. Carcinoma of the prostate is usually a slow-growing cancer that is dependent on the hormone androgen. If prostate cancer is detected early, the probability of cure is high. An elevated PSA can indicate prostate pathology, but is not diagnostic for prostate cancer. The PSA velocity is a trend in PSA levels over time that may indicate the need for further tests to diagnose prostate cancer. A transrectal ultrasound may be performed, and bones can be scanned to detect metastasis. Transrectal, transurethral, and transperineal prostate biopsy and tissue analyses will determine the severity or extent of the prostate cancer. Because prostate cancer is relatively slow growing, conservative treatment may involve monitoring and follow up care. Annual digital rectal examinations are performed, and PSA levels are monitored in high risk patients. When surgical therapy is indicated, a laparoscopic radical prostatectomy is considered the most effective treatment for long term survival before metastasis occurs. An interprofessional approach will integrate surgery, radiation, and androgen restriction. Gamma teletherapy and brachytherapy are used for cancer of the prostate and provide greater preservation of sexual ability. Hormonal therapy is designed to suppress androgen stimulation of the prostate by decreasing plasma testosterone. Provide a sensitive, caring approach to the patient and family to help them cope with the diagnosis and make informed choices. Preoperative care involves the restoration of urinary drainage, prevention of UTI, and understanding the options for treatment and their effect on sexual function. On page 964 within Table 40.3, you can read about some treatment options for prostate cancer. Complications of surgery may include bleeding, catheter obstruction, and sexual dysfunction. Impotence or retrograde ejaculation may occur. The nursing care of a patient with a prostatectomy includes reducing anxiety, relieving discomfort, maintaining fluid balance, monitoring for bleeding or infection, catheter care, and teaching the patient self-care and the need for continued follow-up care. Nurses in the community can be instrumental in teaching and promoting testicular self-examination in men between the ages of 15 and 40 years. Educating all men older than 55 years about prostate cancer screening benefits and its drawbacks will allow them to make a personal decision regarding PSA testing. Nurses in long-term care facilities must be watchful for urinary obstruction in the older adult male resident. Use of a bladder scanner can detect retention. All nurses can be instrumental in teaching perineal muscle or Kegel exercises to decrease the incidence of incontinence. Correcting incontinence also greatly decreases the nursing care time that will need to be spent with the patient, therefore cutting healthcare costs. Home care nurses supervise or assist with dressing changes for patients after radical surgery. They monitor side effects and complications in patients undergoing radiation, teach self-care, and provide psychosocial support for patients with prostate cancer and sexual dysfunction. Nurses in the community can assist patients who are experiencing ED by including assessment for this problem when working with male patients. Knowledge about treatment options, a matter-of-fact, optimistic attitude, and a comfortable manner when speaking about this topic can provide hope and guidance.